All right, so I'm Swati Arora, one of the assistant professors at Allegheny Health Network, and I would like to welcome everyone to today's GlomCon on Clinical Trial Conference Series, which is a joint venture between GlomCon, Neph Kidney International, and American Society of Nephrology. As a reminder, this session is CME accredited by Harvard Medical School, so please log in with your full name. And I would like to welcome our wonderful speakers for today, Dr. Howell, Dr. Vivarelli, Dr. Wadhwani, and Dr. Hogan, who will take us through the journey of clinical trials in C3 glomerulopathy today. And I'm joined by a team of moderators with Dr. Sunil Udani, Dr. Kirk Campbell, Lauren Lee, and myself. So next, I would like to invite Josh Thomas, who is CEO of Neph Kidney International, who will tell us more about this initiative and the Kidney Health Gateway.
Wonderful. Thank you for the very kind introduction. Lauren Lee has deserved a very good day off, and so I'm pinch hitting, so thank you for the welcome. So I would like to, again, welcome everyone and thank you for your participation. We're coming off of the American Society of Nephrology meeting last week, and we were, as a number of us were discussing, incredibly encouraged by the vast number of interest and panels and presentations regarding glomerular disease, and in particular the clinical trial orientation in general of that topic. I'd like to say also we're grateful to the organizers and the host today, and also KEY, Kidney Health Initiative under the ASN umbrella. I would, as you mentioned, like to invite everyone to visit, if you haven't already, Kidney Health Gateway. That's all one word. You'll find in there is that we launched last year a portal for healthcare providers. This tool was developed being very patient-centric, kind of a match.com, if you will, for patients to all available clinical trials, both longitudinal observational as well as pharma-sponsored interventional trials. To help things along the way, this physician portal is a gateway for not just the clinical trialist, but also for the general nephrologist to find out what trials are available in his or her zip code, as well as find out, connect with a glomerular disease expert as well. There's also a roles and responsibilities code that we've launched in terms of how does the interaction among the patient, the clinical trialist, and the general nephrologist all work together to make sure that we provide the best patient care. So I encourage you again to go to that website. I think you'll find a lot of resources. So with that, I thank you very much and turn it back.
Great, thank you, Josh. So our first speaker is Dr. Jean Howe, who's an assistant professor at Cedars-Sinai Medical Center in Los Angeles, California. She'll be walking us through disease epidemiology, current therapies, and the major knowledge gaps in C3GN. She trained at the Georgetown University of Medical School, completed residency and fellowship at Columbia University, and has a special interest in C3 glomerulopathy. So Dr. Howe, thank you very much for joining us, and let's take it away.
Okay. Thank you for the opportunity to take part in this conference today. I was actually introduced to the world of C3 glomerulopathy during my renal pathology fellowship, where I helped develop the immunofluorescence criteria for diagnosing C3G. So it's really a particular honor to be invited to speak a little bit about the background of this disease and also to touch on the pathologic features. Next slide. So I think it's easiest to understand the concept of C3G if we understand how this term evolved, and that story starts with the term membranoproliferative glomerulonephritis, or MPGN. I know through many discussions that I've had with clinicians that this term MPGN does cause some confusion because from my or a pathologist perspective, it's not really a clinical diagnosis, but a histologic term that describes the pattern of glomerular injury, which is the duplication of the glomerular basement membrane, which is shown on in higher power on the box in the bottom part of the screen. Other terms we use to describe this finding is tram tracking or double contours. This change can be very focal, or next slide. Sorry, next slide. Oh, there you go. Or it can be more extensive. You can leave it there, that's fine. Involving the entire glomerulus. So in immune complex mediated MPGN, these double contours actually form as a result of immune complex deposition along the GBMs. And it's actually just the glomerulus's response to this injury. Next slide. So historically, these cases of immune complex MPGN were subdivided based on electron microscopy findings, which is namely the distribution pattern of these immune deposits with respect to the GBM. So this was just a first step. It was trying to subcategorize these cases based on ultrastructural findings, but it had nothing to do with causation. So just briefly, in MPGN1 in the upper left, the deposits are primarily subendothelial or on the inside surface of the GBM. MPGN2, which is also called dense deposit disease, due to the really characteristic intramembranous deposits, which we often describe as sausage on a string. And MPGN3, where the deposits were both subepithelial and subendothelial, and this is even further subdivided into Burkholder and Strife-Anders variants. So this is where the story stalls for a while. We as pathologists could tell you that there was an immune complex mediated MPGN, but then it was really kicked back to the clinicians to find out what the cause of this lesion was. And those causes could be infection, autoimmune disease, malignancy. Next slide. The change in perspective really came when we started looking at these cases not in terms of where the deposits were located in the glomerulus, but actually what these deposits were made of. So this is where immunofluorescence studies come in. In a typical renal biopsy, we run an entire immunofluorescence panel, which includes 3 immunoglobulins, IgG, IgA, and IgM, 2 complement proteins, C1q, C3, and kappa and lambda light chains. And you can actually see any combination of these immune complex reactants in an MPGN case. Next slide. But the breakthrough really came when it became obvious that there was a subset of these MPGN cases that were staining very strongly for C3 alone without significant staining for the other reactants. Next slide. So what was causing this particular pattern of IF staining? And this is where we turn to the complement system. So this is a highly conserved part of our immune system, which basically functions to complement or help antibodies and phagocytic cells eliminate pathogens and damaged cells, and it also promotes inflammation. So it involves a number of factors with really complex interactions, and I've simplified this a lot in this slide just so I can draw attention to a couple of the key points. The first is that this system is actually composed of 3 pathways, each with its own trigger shown at the top. The lectin binding pathway is triggered by microbial polysaccharides, the classical pathway is triggered by antigen-antibody complexes, and then the alternative pathway, which is what we're going to focus on, which is on the right, which is really the key to C3 glomerulopathy, can be activated in the fluid phase, meaning in circulation, and not on foreign cell surfaces. So this alternative pathway is continuously active. There's a low-grade self-propagating mechanism that we call tickover. So the next key to this slide is noticing that all 3 pathways, even though they have distinct triggers, they all converge into a final common pathway with the formation of the membrane attack complex at the bottom, which is ultimately inserted into the cell surface and causing cell death. Next slide. So focusing just on the alternative pathway on the right, you can imagine that a system like this must have built-in safety controls to keep it in check. And indeed, there are a series of negative regulators, some of which I've depicted here in the red icons that work at different points in the pathway. So these are like the brakes in your car. They function to slow or halt the system. So imagine if you, for whatever reason, happen to develop an antibody to one of these negative regulators or any other players in this pathway. Next slide. And I've shown some of these in green here. So if you happen to develop an antibody that makes these inhibitors ineffective, you've basically taken your foot off the brake and stepped on the gas. And so this pathway can continue unchecked. Alternatively, imagine that you developed a stabilizing antibody, not an inactivating one, but a stabilizing one against one of the key enzymes, which now makes it continuously active, also causing overactivation. Or imagine that you've inherited a genetic mutation in any one of these proteins, which can also result in alternative pathway dysregulation because these abnormalities are not only required, but they can be genetic as well. Next slide. So the net result is that the alternative pathway basically goes off the rails and you end up with uncontrolled deposition of C3 split products on the cell surface. Next slide. So what does this mean in terms of glomerular disease? You can suspect, or we can suspect, that something has gone wrong in the alternative pathway just by looking at the immunofluorescence. So you remember in the classical pathway diseases, those are triggered by antigen-antibody complexes. You'll see C3 deposits on the glomeruli, but also in the presence of other immunoglobulins, most typically IgG and IgM. In cases where there have been overactivation of the alternative pathway, which remember occurs in circulation and doesn't require an antigen-antibody complex, you can see strong C3 deposition in the glomeruli, but without really any other significant staining for immune reactants. Next slide. Next slide. Okay, so this brings us to the present. So that subset of cases of immune complex MPGN that showed strong C3 staining alone or with what we define as sort of background staining for the other immune reactants, can now be taken and reclassified based on a suspected pathogenic mechanism, which is alternative complement pathway dysregulation. So that umbrella term C3 glomerulopathy at the bottom of the slide includes cases of dense deposit disease, and we retain the original name because this was really the prototype disease for C3G, and because it has really distinctive EM findings, as well as those cases of NPGN 1 and 2 that had C3 dominant staining, and those cases are now called C3 glomerulonephritis, or GN. So now we have an actual diagnostic term that can identify a patient population that might actually benefit from alternative complement pathway testing in order to try and identify an abnormality. Next slide. Next slide. So now that the diagnosis is based on immunofluorescence findings, really, and not the ultrastructural features, it's not surprising that the actual pathology is quite varied, right? So it can range from mesangial proliferative GN, which is shown in the upper left, which is just massive C3 deposits in the mesangium, to a more proliferative phenotype, which is on the upper right. Because you remember, C3 can also attract inflammatory cells, where the glomeruli appear very hypercellular, and then these changes can also include crescent formation in the bottom left, as well as necrosis in the bottom right with GBM injury and rupture. So even the immunofluorescence pattern of the C3 deposits can be quite varied. You know, some of them can be rounded in the mesangium or linear in the GBMs, as shown on the left, or it can be more diffuse in the glomeruli, as shown on the right. So while the distribution of the C3 deposits may vary, the one thing that they have in common is that the C3 staining must be the dominant deposit. And this has been defined as being 2 orders of magnitude stronger in intensity than any other immune deposit. Next slide. So now we can talk a little bit about the epidemiology of the disease. So this is an extremely rare disease. The incidence is estimated at 1 to 2 million cases per year and is diagnosed in about 1 to 2% of all kidney biopsies. The initial diagnosis can really occur at any age in life, although there are some studies to suggest that dense deposit disease might affect a younger patient population, while C3GN affects an older. There does not appear to be a gender predisposition. It affects men and women equally, and most of the patients are Caucasian. And at the very bottom, this is really based on the largest series of C3G to date from the Mayo Clinic. When they went back and looked at a well-defined series of patients with C3G, about a third of them had an underlying monoclonal gammopathy. A little more than a third had a history of infection, and a portion also had a history of autoimmune disease. And on the right in red is why we actually really need to develop effective therapies, because the renal prognosis is very poor. Up to 50% of patients will progress to ESRD within a decade. And if these patients do go to transplant, the recurrence rates in allografts are about 45 to 60%. And that is my last slide.
Thank you so much, Dr. Howe. Just a quick question. So whenever you see only C3 positivity on immunofluorescence, do you always send that for pronase digestion looking for masked immunoglobulins, or is it like you would send some and not others based on certain other criteria?
Yeah, we don't routinely send all of them, but we do send it if the patient happens to be older, if we're given the history that a patient has some sort of underlying MGUS or MGERS.
Very good. Thank you very much, Dr. Howe. Our next speaker is Dr. Marina Vivarelli. Dr. Vivarelli is a clinical laboratory researcher as well as consultant in pediatric nephrology at the Bambino Gesù Children's Hospital, the largest pediatric hospital in Europe. She's conducting several clinical trials in C3GN, and with her colleagues takes care of a cohort of approximately 40 patients with C3GN, as well as being a co-author for the KDIGO guidelines for nephrotic syndrome in children. Vivarelli will walk us through the current understanding of targets and pathways for new drugs and drug development. So thank you very much, Dr. Vivarelli.
Thank you for the kind invitation, and apologies for the technological mishap. Next slide, please. These are my disclosures. I collaborate with many pharmaceutical companies involved in the world of complement. Next, please. Yeah, so I wanted to start by giving you a sort of brief overview of the state of the art of how to treat these patients. And my other main disclosure is that I'm a pediatric nephrologist. So I'm not going to touch in any way on the whole world of C3G secondary to monoclonal gammopathies, which is mainly anyhow dealt with by dealing with the monoclonal gammopathy. In terms of all the other forms, which are secondary to an alternative pathway dysregulation, in complement, as Dr. Howe has already very nicely explained before me. We don't have any randomized controlled trials to guide our treatment strategies. So in 2017, KDIGO got a controversies meeting with experts who sat around a table and tried to agree to give some guidance based simply on their expert opinion. And what we came up with was, next please, yeah, that for all patients, it was absolutely necessary to have optimal blood pressure control and low sodium diet and lipid control. And further, next please, in case of moderate disease, defined as moderate inflammation on the renal biopsy in a proteinuria above 500 milligrams per day, it was a reasonable approach to use conventional bread and butter immunosuppression with prednisone and mycophenolate mofetil, which has been also confirmed by retrospective studies that have been performed both in Europe and in the United States. In the case of more severe disease, next please, defined as a nephrotic range proteinuria and a severe inflammation in the renal biopsy with or without renal failure, you could up your immunosuppression with more aggressive IV methylprednisolone, BOLA, and anticellular immunosuppression such as cytoxan. And it was deemed that there was insufficient evidence to recommend eculizumab, one of the main complement inhibitors that are being used for atypical HUS, as first-line agent. However, when a further meeting was of experts took place in 2018, reviewing the evidence and reviewing the new complement inhibitors that are coming down the pipeline that I will discuss, next please, it was recommended to consider anti-complement targeted therapy. And for anyone who wants a brief overview of the state of the art of these diseases in 2019, I recommend the review by Richard Smith's group and a group of experts published this year in Nature's Reviews Nephrology 2019. Next. So when we're thinking about what is happening in the renal glomeruli of patients with C3 glomerulopathy, notwithstanding what is going on upstream, so looking at the different ways in which the alternative pathway can be dysregulated, a common feature that whatever mechanism will be determining at the glomerular level is, next, an important degree of inflammation with lots of neutrophils, lots of monocytes, and lots of mesangial proliferation, especially in the acute active phase of disease. This is the reason why conventional bread and butter immunosuppression can be effective, especially in recent onset forms of C3 glomerulopathy. However, obviously, this is not acting at the root of the disease. And if we want to do this effectively, we have to do something that modulates, next please, at this level, acting on whatever it is that dysregulates the complement in the different patients. The problem is that we have a very limited understanding of what specifically is happening in each one of our patients that have C3 glomerulopathy, and this is highly heterogeneous between one patient and the next, even though the histology and the clinical picture may be very similar. Next, please. So this is a brief overview of the pathways, as has been already shown by Dr. Howe. And what I wanted to show you is that up to a couple of years ago, the only agent that we had that is approved and that we have quite a bit of experience with for another complement-mediated kidney disease that is not a glomerular disease, which is atypical HUS, is eculizumab. Next. So eculizumab acts right at the bottom, right at the beginning of the terminal pathway of complement, blocking C5, the C5 protein, which then goes to form the terminal complement membrane attack complex. And it is a monoclonal antibody, and it is extremely effective in shutting off the terminal pathway of complement. As far as experience in C3 glomerulopathy goes, next. We have treated the first patient in our hospital in Rome who was a child with DDD. And in this specific case, we had a really spectacular result. He had nephrotic range proteinuria, and for the whole time that he was on eculizumab, his proteinuria went significantly down, and we also saw an improvement in terms both of immunofluorescence and of thickness of the capillary walls in the kidney biopsies that we reperformed, with a re-increase in proteinuria when we interrupted eculizumab and a re-decrease in proteinuria when we started again. So we were really encouraged by this first single case. However, next please. Subsequently, a lot of case studies, retrospective studies, and a lot of further experience came down the line. Keep in mind that this paper was published in 2012, so 7 years ago, and definitely not all patients respond so well. It is also, as we know, an extremely expensive therapeutic agent, and it also has a significant risk of meningococcal infection. So now I wanted to show you how we did learn some lessons from all the different physicians that gained experience treating children and adults with C3G with eculizumab. And I summarized here some of the main retrospective studies and the only prospective clinical trial performed, which is called the EAGLE study, performed by the Bergamo group, and also a couple of reviews on this topic. And the take-home messages that we learned from our trials and also our errors, because more globally we can say that about only 1/3 to maybe half of the patients treated with eculizumab for C3G actually do respond. But what we did learn from these experiences is, one, next, that exactly the response to treatment varies very widely, even in patients that seem to have apparently similar features. Next, that when present, the response tends to appear between 1 and 6 months from treatment initiation. And in responsive patients, differently from what we saw initially in our patient, discontinuation can lead to disease relapse that may be refractory to restarting the drug, which is obviously very concerning. Next, that altogether, the response tends to be much more convincing when the disease is initial and when it is rapidly progressive. Next, that the benefits have to be carefully balanced with potential risks, especially in terms of infection, and this is particularly true in children. So it was important to gain experience from eculizumab, but I think anyone who has been trying to improve treatment in this group of patients with this drug has learned that it is very, very frustrating and also very, very difficult to predict who is going to do well and who is not. Next, please. So now in 2019, luckily, as I have shown you here, we do have a whole array of other agents who act at other levels within the alternative pathway cascade, and therefore who can target different points of the cascade and therefore be effective even in patients that do not appear to respond to eculizumab, hopefully. I have here put a list of the different drugs, the different targets, their mechanisms, and the clinical trial numbers. In red, I have put trials that are also enrolling children. Specifically, the last one, the Avacopan trial, is enrolling 12 and up, and the pegcetacoplan trial is enrolling 16 and up for patients with C3 glomerulopathy. And this, especially to a pediatric nephrologist like me, is particularly important. Also because children are more likely to respond because they have a shorter disease duration. Next, please.
And Dr. Vivarelli, just to also briefly then just go back, this is, it is because of this uncertainty you mentioned that the current consensus is to not choose eculizumab as the first-line therapy for C3G.
No, absolutely. So I think the wise approach is to choose to think about a complement inhibitor when conventional immunosuppression has not proved effective, especially in the presence of a lot of florid inflammation in the renal biopsy. Okay, so here I wanted to show you where the different agents that we have that are not eculizumab act, just to give you an idea, and then I know that the subsequent speakers will go into much more detail on the features of 2 of these drugs, but just to give you an idea of the different points in which they may act and how, since we know that when we look at the way in which complement is dysregulated in different patients, we see that in some patients we have the impression that it is dysregulated in a more terminal fashion, and in others it is dysregulated at a higher level, more at the level of the C3 convertase. So having different agents that act at different points is going to be particularly useful moving forward trying to treat these patients. At the same time, their safety profile is also going to be different because we know that complement serves to protect us from infections. So next, the agent called Avacopan is a C5a receptor inhibitor. It has been proven to be spectacularly effective in ANCA-associated vasculitis and the renal manifestations. And it is a drug that acts also very downstream, like eculizumab, but it has the specific feature of having a strong anti-inflammatory action because it blocks C5a, which is an anaphylatoxin. So it is a substance that recruits to the kidney neutrophils and creates inflammation. So it has actually been shown in the ANCA vasculitis trials to be similar to prednisone in its anti-inflammatory effect. So this can be particularly useful in patients with C3 glomerulopathy that have a very florid form of disease. The other drugs that I'm now going to show you act further upstream. So in patients in which the dysregulation is further up, they may be potentially more effective. And they are next, a factor D inhibitor, which is a small molecule which blocks factor D, so effectively acts at the level of the C3 convertase, called Danicopan. Then next, pegcetacoplan is an actual C3 inhibitor. It is a cyclic peptide inhibitor, and it actually binds C3. So it blocks both the C3 convertase and the C5 convertase. And so it can actually increase the levels of C3 circulating, as also Danicopan, as I think will be shown by the subsequent speaker. The last one that I'm going to mention, and these I mentioned because they are all in clinical trials that are currently enrolling adults, and in some cases also children, is next a factor B inhibitor, which is also a small peptide, which is currently, the trial has just starting up, enrolling patients with C3 glomerulopathy. So next, so how do we choose who to treat with which drug? I think this is going to be the big challenge going forward. And I wanted to show you this publication, which was recently published in JASN. And it was a big effort in which 173 patients, both with classic C3G and with immune complex MPGN, but with proven features of alternative pathway dysregulation, because especially in children, in reality, the dominance of the C3 in the biopsy is not always there. You can have a biopsy that also has immunofluorescent positivity for IgG, for example, but in which you either have C3 NAFs or genetic alterations leading to dysregulation of the alternative pathway. And in 173 patients with these features, a cluster analysis was performed, which is a very powerful statistical method in which 34 features, genetic, serologic, histological, and clinical, were put together to identify 4 groups of patients with these types of diseases. And this was useful to try to create groups that then can be used for clusters, which can then be used, for example, also to stratify when you're designing a clinical trial. So the first, next please. The first 2 groups have elevated C5b9, so they have evidence of a terminal pathway activation. The first group is the classic C3G because it has predominant C3 bioimmunofluorescence, and the second one does not. The third group, next, is a group that has normal C5b9, though it has low C3. So these are patients which you can imagine that the dysregulation is happening further up. So where it can be useful to probably block the C3 convertase more than the C5 convertase. And these more frequently have dense deposits by electron microscopy. The fourth group is a group of mainly adults, next. with late onset marked sclerosis and poor outcome that strangely have both normal C3 and normal C5b9, and in which it appears that the dysregulation is more a low grade, more solid phase with infrequent mutations in alternative pathway or C3-NAF. These patients tend to have a worse prognosis next and to be a different group. So I think I showed this because I think that this study is important in giving us the idea that not only is this a very rare disease, but also it's a very heterogeneous disease, but that stratifying these patients can be important to treat them in a smart way. Next slide, with which I conclude. So the premise to effective treatment of C3 glomerulopathy in 2019 with this array of new drugs that is coming through and that we are going to test is that it is very heterogeneous. Alternative pathway dysregulation occurs at different checkpoints in the pathway in different patients. The future, therefore, is tailored treatment based on a deep phenotyping and genotyping approach. And we absolutely need collaborative studies in order to achieve this because we need large numbers of patients in order to be able to make meaningful conclusions. Thank you very much.
Thanks so much, Dr. Vivarelli. And with that, we'll start discussing some of the active studies in C3G. So our first speaker in this part of the conference is Dr. Shikha Wadhwani. She's an assistant professor at Northwestern, where she leads the glomerular disease program. And Shikha did her residency and fellowship in nephrology at Rush and a GN fellowship at Ohio State. She'll be talking today about the Avacopan study targeting C5a receptor. So Shikha, welcome.
Thank you. Can you hear me okay?
Yes.
Okay. All right. So next slide, please. I just want to thank you all for the invitation to be part of this program. It's truly an exciting time, I think, in terms of clinical trials in nephrology. And although SGLT2 inhibitors seem to be getting all the hype these days, I am the first to admit that I'm a bit glomerulocentric. I'm glad to see GlomCon joining forces with NephCure to really highlight these rare diseases for which we have talked about. We really need safe, efficacious, and targeted therapies. So today, I'll talk to you about the Accolade study and the study design and the rationale for this randomized, double-blind, placebo-controlled phase 2 study to study the safety and efficacy of Avacopan in patients with C3G. Next slide, please. So we've already heard a lot about complement from our prior speakers, and I think we're all comfortable with the fact that the alternative complement pathway is implicated in C3 glomerulopathy. As Dr. Vivarelli mentioned, we unfortunately have no approved therapies with an indication for C3G presently. There have been small series and case reports showing efficacy with some non-specific treatments borrowed from other GNs, but we're continuing to learn more about the complex interplay of regulators and activators in the alternative complement pathway, and we now have some targeted treatments, as were mentioned, that are ready for testing in clinical trials. So also, was mentioned how C3G is a very heterogeneous disease, and based on the number of different mutations and autoantibodies to complement components that have been identified, and honestly many which have not yet been identified or fully understood, there simply can't be a one-size-fits-all complement targeted therapy. But that being said, I think we have a few drugs that do attack different parts of the alternative complement pathway, and hopefully we'll see some positive results in both the trials Dr. Hogan and I will present today, and be able to offer our patients new therapies and move towards identifying which therapy would benefit which patient, as previously mentioned. So I'll spend the next few slides talking about the Accolade study, which focuses on the deleterious effects of C5a and inhibiting those. So as was mentioned, we know that C5 convertase cleaves C5 into C5a, which is a potent anaphylatoxin and inflammatory mediator, while C5b joins C6 through 9 to form the membrane attack complex, which is important for bacterial cell lysis. Now, it was mentioned blocking C5 with a monoclonal antibody such as eculizumab has worked for some patients with C3G. It's not entirely clear if that effect was exerted through blockade of C5a or through C5b through 9, and there has been some indication that patients which responded had greater activation of the terminal complement pathway. But given the importance of the terminal complement pathway in protection from bacterial pathogens, especially encapsulated organisms such as Neisseria, there was this interest in developing a drug that targeted this pathway while leaving the protective effect of the membrane attack complex intact. Next, please. So this is where the study drug Avacopan next comes into play. It selectively blocks the receptor to which C5a binds. Next. Okay, and next slide. So Avacopan, formerly known as CCX168, is a orally administered, highly selective small molecule inhibitor of the C5a receptor. And there's preclinical data in a mouse model of a lethal C3 glomerulopathy that showed that C5a receptor deficiency significantly reduced disease severity. So if you look at the left panel, you see renal tissue from a factor H knockout mouse treated with antiproperidin antibody, which shows a C3G phenotype, and in this case characterized by mesangial proliferation and glomerular crescent formation. Now contrast this with the right panel, which shows factor H knockout mouse crossed with a C5a receptor deficient mouse, and you see amelioration of the phenotype with much more normal appearing glomerular architecture. And in the graph below, you see that those same mice had significant reductions in albuminuria when compared to the factor H knockout mice, suggesting again the importance of C5a receptor in mediating inflammation in C3G and as a potential treatment target. So what about human data? There's phase 1 data looking at Avacopan in 48 healthy volunteers that showed it was safe and well tolerated at varying doses. And as was previously mentioned, there's phase 2 data from ANCA-associated vasculitis trials, including the CLEAR trial, which noted that Avacopan was efficacious in reducing the BVAS score, had an antiproteinuric effect, steroid-sparing effect, improvement in quality of life when added to either Cytoxan or Rituxan in the treatment of ANCA-associated vasculitis. And there is a phase 3 trial, the Advocate trial on ANCA-associated vasculitis, which has completed recruitment and hopefully will have results in the next year or two. But for now, I want to talk about the active phase 2 study for C3G, which is ongoing and actively recruiting in 37 sites, 8 in the US and the rest in Canada and Europe. Next slide, please. So the Accolade study, the inclusion criteria include age greater than 18 years in the US, but adolescents aged 12 to 17 may be enrolled in approved European sites. And then the other inclusion criteria is, of course, proven C3GN or dense deposit disease within 12 weeks prior to screening or during the screening period. And it's important to note that given this is one of the most rare diseases among glomerular diseases, the inclusion criteria are fairly broad. So if we look at the upper panels A through C, these are images from a patient with dense deposit disease. The bottom panel is patients with C3G. Next, the important factor in study inclusion next is the immunofluorescence pattern, which Dr. Howe reviewed, requires C3 staining of 2 orders of magnitude greater than any other immunoglobulin light chain or C1q. Next, on light microscopy for enrollment in the study needs to show proliferative glomerulonephritis with mesangial or endocapillary hypercellularity. Next, and finally, electron microscopy must show electron dense deposits that correspond to the immunofluorescence pattern. So the exclusion criteria are fairly standard, but notably patients with greater than 50% tubular interstitial fibrosis are excluded from this study. And this is, of course, somewhat subjective and can be subject to sampling error. Secondary forms of C3G, not as well characterized as in other glomerular diseases such as membranous, but as was previously mentioned, there is a subset of patients with C3G that have an associated monoclonal protein, and those patients would not be eligible for this study. And then I want to focus your attention on the right side. The use of eculizumab or another anti-C5 antibody within 26 weeks prior to dosing for the study would be an exclusion criteria. So next. This study, I think, is fairly unique when you look at other glomerular disease trials. There's no proteinuria or eGFR cutoff, And patients with a prior diagnosis of C3G may be eligible to participate if they're willing to obtain a renal biopsy during the screening period and, of course, meet the pathology criteria. Additionally, this is pretty unique. Patients with recurrent C3G after transplant can be eligible for this study. And concomitant immune modulating medications are allowed as long as the dose is not increased during the study. So for example, I have a patient who is on CellCept and is also in the study at this moment. Again, eculizumab or other anti-C5 agents are exclusionary. Next slide. So the study design starts with, a screening period that can last up to 6 weeks in which the biopsy must be confirmed to meet criteria for C3G. Patients are then stratified by their C5b through 9 levels, as well as substratified by their disease, dense deposit disease or C3GN, and by transplant status. They are then randomized 1-to-1 to receive either Avacopan 30 milligrams twice daily or matching placebo twice daily for 26 weeks. And then all patients undergo a repeat renal biopsy at week 26, which, as I will get into, is the basis for the primary endpoint. And then after week 26, all patients will enter an open label period where they will receive Avacopan 30 milligrams twice a day for an additional 26 weeks. And this is followed by a week 52 biopsy and then an 8-week follow-up period off drug. Next slide, please. So this is the last slide. Looking at the study endpoints, the primary endpoint is actually a change in C3G histologic activity index from baseline to week 26. Next, please. As shown here, this is the C3 histologic index that was developed by the Columbia group and published in 2018. And it really looks at a variety of different pathological features, including mesangial hypercellularity, crescent formation, that comprise the activity score, and then also tubular interstitial fibrosis comprising the chronicity score. And this is really the basis of the primary endpoint for this study rather than proteinuria or renal function. So I have the secondary endpoints listed there as well. And with that, I will go to the next slide. Here are just some additional resources and information, especially for patients and family members that might be interested in learning more. And if there are no questions, I'll go ahead and give it back to you guys.
Thanks so much, Dr. Wadhwani. I think we'll save the questions for the end. This is now time to introduce our next speaker, Dr. Jonathan Hogan. He's an assistant professor and director of the clinical director of the Penn Glomerular Disease Center. Dr. Hogan did his residency training at UPenn and completed a fellowship in nephrology and GN fellowship as well at Columbia before returning to Penn, where he's been a leader in many clinical studies across a number of indications. But today he'll be discussing the Danicopan study targeting factor D. So welcome, John.
Thanks. Can everybody hear me okay?
Yes.
Yeah, okay, great. Thanks so much to GlomCon and to NephCure for the opportunity to give a few slides on the Danicopan study. Just to emphasize as a disclosure that I am a site PI for the study at Penn with salary support. Next slide, please. So these slides were provided by Achillion. So this is publicly available data and discussing complement-focused treatments and patient-driven treatments and outcomes as well. Next slide, please. So the molecule that Achillion is studying and that we'll be discussing today is Danicopan, which is also known as ACH4471. So this is an oral factor D inhibitor and has been tried in a few diseases that involve the alternative complement pathway, including paroxysmal nocturnal hemoglobinuria and C3 glomerulopathy, with plans for further expansion into broader indications. So this is an oral small molecule inhibitor of factor D. Next slide, please. All right, so I know I'm only supposed to do 6 slides, but I figured I would take this opportunity to take about an hour and a half to again reiterate. No, I'm just kidding. I'm just kidding. The complement pathway to me is one of those things that's extremely daunting, and I'm happy that the prior experts today have done an excellent job in showing their expertise on the pathway. But suffice to say that in the context of this study, we're talking about inhibiting factor D. And as you can see here, factor D, it's involved in this amplification loop, as well as in the alternative complement pathway, and basically amplifies the complement pathway by cleaving C3 into C3BB and C3BA, and therefore having this amplification loop and downstream activation towards the membrane attack complex to promote inflammation and cell death. So I think I'll leave it there, but we think it is a key component of what drives both the alternative and the terminal complement pathways. And so it seems to be a suitable target for blockade in diseases for which we think this is important, like C3G. So next slide, please. I'll actually tell a brief story because I only have 6 slides, is that like when the C3 glomerulopathy was being described, the ASN, there was entire sessions and oral abstract sessions on C3 glomerulopathy. And during one of them, somebody stood up and was walking out of the session and said, "I'm tired of all this C3 glomerulopathy." And he yelled it out as he left the meeting, which was, I thought, pretty funny. That's my brief foray into a story. And moving back to the study. So there's there's an ongoing phase 2 C3G study with Danicopan. So there was a 12-month open label trial for which 22 patients are enrolled. And there's a 6-month blinded trial for which 13 patients are enrolled. So we are participating in the 12-month open label trial for which we have enrolled 2 patients. And this is all being compared to the C3G real world evidence, which is kind of a historical cohort study to try to understand how the treatments that are used with oral factor D inhibition will affect the natural history of the disease. And the initial design of the study is actually to compare kidney biopsy scores. So there is a biopsy at the beginning of the study and at the end of the study at 1 year. And also looking at reductions in proteinuria, we're looking at changes in GFR, and looking at complement levels and various complement assays to assess for complement activity. And these data are being used to complete an assessment to support a phase 3 design. So next slide, please. So here's the design of some of the initial data that we'll be showing, because there's no data to show for the randomized trial or the placebo-controlled trial or the open label. But this was the clinical trial design for group 1 in some initial data. So the key inclusion criteria is that patients must have C3G or immune complex MPGN, because it has also been shown in some studies that the alternative complement pathway is activated in immune complex MPGN as well. And the patients must have had a low C3 with a normal or near normal C4. They got 14 days of treatment and then tapered off treatment and were followed for about a month. And the data I'm going to be showing you is 6 patients that underwent this trial design. This completed enrollment in December 2018. And you can see here, we have the changes in biomarkers, the clinical manifestations in terms of renal parameters, safety, tolerability, and the pharmacokinetic profile are the things that are being studied. So next slide, please. So these are the 6 patients that Achillion has published on. So this is the percentage biomarker change from baseline day 1 to day 14 at the end of treatment. And the interpretation was that there was positive signals for reduction of alternative complement hyperactivity in all the biomarkers. So to orient you on the biomarkers that are being shown is serum C3, which we would hope with oral factor D inhibition would increase. Factor B, C3BB, which is a cleavage product after factor D is active should go down by reduction of the cleavage product. Urinary C3BA should also go down as represented by, again, as a sort of representation of decreased activity of factor D. The urinary C5b through 9 should go down if this is active, as evidence of less membrane attack complex being formed and excreted in the urine. And from a renal endpoint, we would hope that the urine albumin to creatinine ratio would also go down. So as you can see across the board for serum C3, that for 4 of the 6 patients, there wasn't an increase in this level. The serum BB levels were decreased in all 5 patients. The urinary BA levels were decreased in all 6 patients, and again, was decreased in all 6 patients. The urinary C5b through 9 was decreased in all 6 patients, and the urine albumin to creatinine ratio over the 2-week period also decreased in 5 out of the 6 patients. So you can see here, there's a link to the clinical trial at the bottom. And this is the sort of, the data supporting the fact that oral factor D inhibitors do have possible, meaningful inhibition of the alternative and terminal complement pathways as represented by these biomarker changes. So that's just a brief overview of the study. The study that we're participating in and the others is ongoing. And again, we'll have over 30 patients combined in those 2 studies. And hopefully we will be able to discern, again, which patients may benefit from this sort of targeted therapy. So thanks so much for your attention, and I'm happy to be involved in any discussion or questions.
Great, thank you so much, our speakers. And there are a few questions in the chat. Dr. Aurora will bring them up, and Dr. Campbell and Dr. Wadhwani will discuss. Perhaps before we move on, I have a question which I can't hold back, but even more important than that, I want to thank the NephCure Foundation, Josh Tarnoff, Lauren Lee, Emma Palitz, and Rebecca Cook, and the entire foundation for their support and then enabling this initiative. This was a fantastic session today. So without that, maybe the first question to Dr. Howe and Dr. Vivarelli. This is a very rare disease, and those who present are very heterogeneous, both etiology-wise, often the pathology and the clinical presentation. Are we doing it justice? Is there to put them all together and enroll them in a trial? Are we setting the trials potentially for failure in the sense that the patients with the same pathological presentation or the same diagnostic criteria may have an underlying difference in the disorder of the pathway, which may or may not influence how they respond? Case example, eculizumab affects the terminal pathway. Some patients respond, most of them not. A trial of that would clearly fail, but doesn't mean that no one is going to benefit from it.
I think in terms of eculizumab, one of the criticisms is that it's kind of like, because it works at the final common pathway, it's sort of like putting a clog in your drain. While you can stop the drain from leaking, it's not going to stop the water from flowing or the entire bathtub from overflowing, for that matter. So I think that really points to a need for, additional drugs that act more proximally in the alternative complement pathway.
Yeah, I have another comment. There are large cohort studies that have tried to examine more in detail at what point in different children or adults the alternative pathway is dysregulated, and that point in some patients to there being more of a C3 convertase dysregulation, and in some patients to be more of a C5 convertase dysregulation, especially Richard Smith's group in Iowa and Veronique Fremont-Baqui's group group in Paris have done a lot of these studies, and there's a lot of information regarding this. So a deep phenotyping does allow you to get an idea of where you think the dysregulation is taking place. However, if you act very much downstream, like you do when you use eculizumab or Avacopan, sooner or later it's going to get there. Obviously, the point is that if you have a defect that is primarily higher up, it would be more rational and potentially more effective to act higher up. So we need to have more of a precise idea of what's going on in each patient. This is extremely difficult, and in the absence of this, stratifying patients so that we put them into trials, keeping in mind what these features are and having as precise an idea of their genetic, serological, and histological characteristics as possible will allow us retrospectively to then understand which patient can benefit more from one drug rather than from another. I think with eculizumab, what happened was that these studies were not performed, so it was just done in a very unsupervised, unstructured fashion, and it really failed to give us very clear information of what was going on. So we need to learn not to repeat this mistake going forward with these other drugs that we need to formally assess. And I think that's one of the good things that we are doing with these trials that are enrolling more comprehensively and studying very deeply the patients enrolled.
I'd like to ask a sort of a corollary question, but more from a general perspective. To those of you conducting these studies, what have you found to be the aspects of the study design that have been more or less appealing to patients? Because there are some differences, and especially with the rare disease, kind of optimizing recruitment. So just like to hear you guys' experience.
So I can speak to that. I think that while this is an extremely rare disease, this is actually the one that we've recruited best for. And I think part of it is there is no standard of care. So patients are looking for answers, and they're looking to be a part of new treatments. I think the other big thing is that with our study, patients are going to receive study drug at some point during the study regardless. When you look at other studies in FSGS, IgA nephropathy, patients are sometimes end up in the placebo arm, but if we can tell patients that, after 26 weeks of treatment, you will be an open label study drug, I think they feel that there is more of an impetus to participate. And I will say maybe one of the things that I thought would be challenging with this study was the number of kidney biopsies, but I haven't found that to be something that has deterred patients, even though it requires a biopsy at 6 and 12 months in our study, in addition to the screening biopsy.
Perfect. I have another question from the chat. Dr. Aga is asking, so is there data on the mutation in factor H and I, on the terminal mutation that predicts whether it's going to be a C3GN kind of phenotype or atypical HUS?
So I can take that if you'd like. The types of mutations that give either atypical HUS or C3G are typically considered to be different mutations, and even regarding mutations in complement factor H and complement factor I. However, this is not always the case. There are patients or families of patients in which the same mutation can give in one individual C3 glomerulopathy and another individual atypical HUS. So in reality, these two disease entities are really at the opposite end of the same spectrum. And one of the things that I didn't have time to mention, for example, was that in very rare patients that we have had treated in our center in Rome that had a mixed phenotype with features of atypical HUS and features of C3 glomerulopathy, these tended to respond particularly beautifully to eculizumab, which is not surprising because in this case, the activation was mainly in the terminal complement pathway and mainly at the membrane bound level, which is really where you get the maximum benefit of a drug like eculizumab.
Perfect. Thank you so much. And one more question, Dr. Vivarelli. You had mentioned that in patients that we had categorized as group 1 and 2, who had elevated levels of membrane attack complex. So does or do measuring the serum membrane attack complex levels correlate with the disease activity or response?
So that's a really good question. The Columbia Group initially in 2012 published a retrospective cohort of patients treated with eculizumab for C3 glomerulopathy. And they clearly indicated that if you had elevated soluble C5b9, you would respond better to eculizumab, which completely made sense. And the subsequent clinical trial that was designed by Professor Remuzzi in Bergamo took this into account, and in the inclusion criteria included only patients with very elevated soluble C5b9 to be enrolled to receive eculizumab. This is the EAGLE study that was published last year, based on the idea that these would be the patients that would respond best to eculizumab. In reality, for reasons that we don't really understand, this was not the case, and 2/3 of these patients did not respond. And in my clinical experience, I've had patients responding beautifully to eculizumab that had absolutely normal soluble C5b9. So clearly there are second hits, and the pathway is much more complex than we had previously envisaged. I think the main take-home message that we have now regarding eculizumab is that rapidly progressive forms tend to benefit, but we really have trouble predicting who is going to respond. And that is why I really think that we are going to be forced to take a backwards approach, in which we enroll the patients that we have, we give them the different drugs depending on what is available for each patient. And then retrospectively, we will try to learn why one drug works better than another drug in a specific subcohort of patients. This is clearly not ideal, but I think it's what we are going to need to do with the current state of the art of our understanding of the disease.
Perfect. Thank you.
So Colin Geddes here from Glasgow. Can I ask our experts a question, please? If this is a disease characterized by activation of the alternative pathway throughout the circulation, why is the disease confined to the glomeruli?
In reality, it's not confined to the glomeruli. These patients, it's a systemic disease because the dysregulation is in the fluid phase. And these patients, for example, can have deposits of C3 in the eye, leading to so-called drusen, which are these little deposits in the subrational space, which can, over time, even give blind spots in much older population. However, mainly it happens in the kidney for reasons that are partially understood and partially not understood, but certainly because it is a heavily vascularized organ with very, very intense filtering of the blood. And so the C3 that is dysregulated in the fluid phase tends to deposit mainly in the glomeruli. There are also, in some cases, evidences that the dysregulation is less in the fluid phase and more at the glomerular level in a subset of these patients, which was group 4 of the cluster analysis that I showed you.
Thank you.
I think we have time for one more question.
I'll speak up. It's Roger Rodby in Chicago. So one of the early slides had the 3 basic etiologies, this being monoclonal gammopathy, complement deficient, complement abnormalities, congenital complement abnormalities, and infection. And I'm always intrigued by the combination of the latter 2, the infection and the complement. That a lot of these people that are thought to have post-infectious GN, for which C3 is really a dominant immunoglobulin, and in adults where it kind of lingers on and on, I've seen some papers that suggest this is really C3 glomerulopathy, and what it is that it's a second hit, that people have have a complement deficiency and they get an infection, and that really what brings a strep infection or whatever, and that's what brings this out. So I wonder what people's thoughts are about this. Is this still a paradigm that's worthy? And if the case, maybe we're missing, it isn't quite as rare as we think, that a lot of these cases are getting identified as a post-infectious when it's really a C3GN.
I can tell you from a pathology perspective anyway, that when we get these biopsies and we see this pattern, where it's really C3 dominant staining, the knee-jerk reaction is not to call it, C3 glomerulopathy. The consensus guidelines actually suggested a term glomerulonephritis with dominant C3, and it truly is a clinical correlation at this point. If I was given a history of recent infection, or there are really typical subepithelial humps that I see on electron microscopy, then I would suggest that it's probably an infection-related GN. But you follow the clinical course. If the clinical course is not typical for a post-infectious, then you might want to consider testing, because perhaps this patient, like you said, does have an underlying abnormality in the alternative pathway that's been unmasked or triggered by the recent infection.
Well, I've seen even the reports claiming that you can get humps in C3 glomerulopathy, and that kind of just gets me back to the real question. How do you make the distinction? It is a clinical distinction, but if you make it by a clinical distinction, you might be missing the real problem. The real problem isn't the strep infection. The real problem is you've got a complement deficiency all along, and these things kind of smolder. And patients with a lot of patients with post-infectious GN, it doesn't go away. They have a chronic GN after that, and I wonder if these cases shouldn't be evaluated. The problem with this disease is that it's so rare. Nobody knows how to identify it. Nobody knows what to call it. And how do you work it up? I mean, how does a reasonable person get complement studies to be able, it says my internet connection's unstable. Hopefully my audio is still coming through. How do you get, how does a regular person get complement studies to make this diagnosis?
So to make a comment from the clinical point of view, clinically, what we say to try to provide guidance to physicians, nephrologists with this quandary, which you're absolutely right, a lot of these patients start looking as post-infectious GN, is if they have a C3, low C3 that persists for more than 8 to 12 weeks, where they have recurrent episodes of intra or post-infectious macrohematuria recurring for more than 8 to 12 weeks. And so that by definition, they do not have an acute GN, but a chronic form of GN, you should reasonably think of C3 glomerulopathy. At that point, even though the features on the renal biopsies you have performed it are difficult to, it is difficult for them to give you a distinction between post-infectious and C3G in many cases, because they can both have humps. And they can both have some IgG as well as deposited in the renal biopsy. What you should do is do a full workup of complement alternative pathway dysregulation, both from a genetic and from a serological point of view. And I know where to point you out to have that done in Europe and the US. I will leave US experts to say that.
Yeah, so in the U.S., there's a couple of different places that we've used, University of Iowa, University of Cincinnati, McCohen Diagnostics. There's a couple of options. I won't say that it's easy. I won't say that it's often covered by insurance companies. One of the nice things about getting patients into trials is we can get some of the complement workup done as part of the trial. But I think to your point, Dr. Rodby, about, identifying these diseases and is it really C3GN on the first biopsy, there are also reports of people being rebiopsied, and the first biopsy may or may not actually meet characteristics for C3 dominant staining, and subsequent biopsies may then illuminate that diagnosis, and that has definitely happened to one of my patients. So I think it continues to be a difficult diagnosis to make in a lot of cases, but hopefully we're making progress in the right direction with some of these consensus statements and algorithms that have been put forth by some of our panelists.
Well, Shikha, you nailed it. You said this is not easy to get, and it's not always paid for. And you put those two together, and it's not going to be diagnosed for the average person. And I mean, I think we need to get this test. Give me an example is PLA2R. For a couple of years, everybody knew about this, but I couldn't get a test done. I just couldn't get it done. Once I finally got it done, it has absolutely changed my practice of obviously a much more common disease. But, if it's not easy, it's not available, it ain't going to get done, and you're not going to make the diagnosis. And clearly it's going to affect treatment. So, to me, that's a major roadblock, is just being able to test for this disease. One is getting it on the radar. Two is, realizing that some of these post-infectious may be actually it, as I was trying to point out earlier. And the three is finding a way to just actually, nail a diagnosis, because you're not going to give eculizumab or any of these experimental drugs unless you're really sure that there's a diagnosis. And clearly these people don't do well without a diagnosis and treatment. And I'll finally shut up.
I hate to abridge the discussion. We clearly have could speak about this for much longer, but we are over time. So I want to thank our speakers again, Dr. Howe, Dr. Vivarelli, Dr. Wadhwani, and Dr. Hogan for leading a excellent discussion. Thanks to Ali, Swati, and Kirk for moderating. I hope you guys continue to join us for the Clinical Trial Conference Series, and we'll see you next time. Thank you all.